Hi all. Welcome to this session on the NEET SS 2025 recall of the infectious diseases questions. As you're all aware, it's a recall session, and the questions and options are based upon whatever feedback that I've received from the students, and there may be some mistakes you can point out in the comments, and I'll be happy to correct. So one question was regarding a post-liver transplantation patient was given a clinical picture of colitis. It was mentioned that the patient had CMV viremia, and the total leukocyte count was given somewhere between low, that is 1,400 to 1,800. So the option were whether like to increase immunosuppression, endoscopy, and mucosal biopsy, or start point is also there. Well, you won't increase immunosuppression when you have CMV colitis, will definitely decrease it, especially the agents like mycophenolate, antimetabolites will decrease. Even if there is CMV viremia, you cannot say that the colitis is definitely due to CMV because viremia doesn't mean that there is tissue invasive disease. You will always want to have an endoscopy and mucosal biopsy. So the correct option will be the endoscopy and mucosal biopsy. Obviously, you won't be starting an antifungal if you're considering CMV as a cause of the colitis. Second is regarding a patient who received 3 doses of rabies pre-exposure prophylaxis now has a dog bite. What is the schedule of post-exposure prophylaxis? Whether it is 03728, it's 03 or 0728. Now, this is a patient who has previously received the rabies vaccine as a pre-exposure prophylaxis. Now, for any patient who have received pre-exposure prophylaxis with 3 doses or have received a post-exposure series of more than or equal to 4 doses, when they have another exposure, another dog bite, so you only need to give 2 doses on days 0 and 3 if the patient is immunocompetent. The patient is immunocompromised, they should also have a documented antibody levels more than or equal to 0.5 international units per. The third question is regarding the management of acute bacterial meningitis in a patient who is more than 60 years old, and the option given are ceftriaxone, vancomycin, ampicillin, ceftriaxone, vancomycin, and ceftriaxone alone, and there was one more option. So this is straight from the Harrison tables which are good. So this is a patient who is more than 55 years, and any patient who is more than 55, there is an increased risk of listeria as well. So in such cases, you will be adding ampicillin to the drug regimen of usual treatment of community acquired bacterial meningitis. So the usual in a patient who's otherwise immunocompetent and less than 55 years, you know that the treatment of choice is ceftriaxone plus vancomycin. But if the patient is more than 55 years or the patient has any immunocompromised condition or alcoholism or other debilitating illnesses, there you will add ampicillin to cover for listeria. So the answer will be ampicillin, ceftriaxone, and vancomycin. The fourth question is a confirmatory test for the diagnosis of leishmania. The option given was spleen, bone marrow biopsy to detect the mastigotes, blood culture, RK39, and PCR. So the definitive diagnosis or the gold standard for diagnosis is to demonstrate the mastigotes and smears of tissue aspirates. And the sensitivity is the maximum for splenic smears, that is more than 95%, and the bone marrow smears will have like around 60 to 85%. So the option A will be correct here, that is spleen or bone marrow biopsy to detect the mastigotes will be the correct answer. So this is how the bone marrow picture or the splenic aspirate picture will look like. So you can see the mastigotes or the LD bodies should have a nucleus as well as a kinetoplast, something that we have discussed many times in our discussion in the doctor tutorials app. The fifth question was a patient post-chemotherapy and steroids who developed a high-grade fever and has something like absolute neutrophil count around 1,400 to 1,800. I think something else like as a recovering neutropenia is what I have understood from the recall from the other students. So the options here include hepatosplenic candidiasis, and the image was given, but you have a CT and you have hypointense lesions in the liver. Now, this possibly is hepatic candidiasis, and it results from the seeding of liver, usually from the gastrointestinal source in neutropenic patients. So typically, it occurs in neutropenic patients when they're recovering from neutropenia. Usually, they will have fever, they will have abdominal pain and tenderness, elevated serum alkaline phosphatase. And hepatic reveal these hypointense lesions, that is like also called as a bullseye lesion. So based upon the recall, what I understand, the answer should be hepatosplenic candidiasis. So this was the image that was given. This question is a 21-year-old patient who presents with complaints of parotid gland enlargement and testicular pain. He has missed vaccination. Which of the following should be advised to the patient? So there will be 30 to 70% risk of subfertility. Meningitis is not associated. Parotid enlargement will persist for more than 3 months, and vaccination is lifelong. Options B and C are definitely wrong. Meningitis definitely is a complication of mumps, and parotid enlargement usually lasts only for 10 days. So regarding A and D, again, vaccination is not lifelong. It's a big kind of statement, but still, vaccination may not be lifelong. In some of these individuals, they still can have not adequate immunity, and moms still can occur. But if you look at the option A, 30 to 70% of suffered, Harrison says that the involvement in these patients, if you look at the involvement of orchitis, it occurs in around 30% of the unvaccinated and 6% of vaccinated postpubertal males. That's the total involvement. And both testes are involved in around 10 to 30% of cases, and testicular atrophy develops in around 30 to 50%. So among the options given, if you look at the options given, I feel that option A is the correct answer, 30 to 70%. There can be a very slight variation in the percentage that is mentioned, but that's the only option which I feel is correct. Now, the patient is a patient who presents with fever for 2 days. A dengue IgM was found to be positive. There was initial improvement in the patient, like to develop pancytopenia and persistent fever. And it was regarding the investigations to be done. Now, this was a typical presentation of a hemophagocytosis, lymphohistiocytosis. Whenever you have an infectious disease, fever persists for a prolonged period. And when the patient develops cytopenias, and persistent fever, you think of HLH, and the initial test that you do, it's the easiest test that you can be done is in the peripheral blood. You can do ferritin triglycerides, and as a second test, you can do the bone marrow study as well. So if this is the first answer, that is ferritin triglyceride bone marrow, there's an option like that is the correct answer over here. So that is secondary HLS due to dengue fever is what's the clinical scenario. You start with ferritin, triglyceride, etc., and go on to a bone marrow study for diagnosis. Next question is, which of the following is not associated with the risk of progression of liver disease and HCV infections? The options included old age, RNA level, chronic alcohol, and long-term chronic HCV infection. This is straight from Harrison. So the progression of liver disease in patients with chronic hepatitis C are more likely in patients who are older age, longer duration of infection, advanced histological stage and grade, and more complex HCV quasi-species diversity, increased hepatic iron, and concomitant liver diseases, which could be alcoholic liver disease, etc., HIV, and obesity. Now, among these variables, the duration of infection is the most important factor which decides whether the patient goes to chronic hepatitis, like whether this is progress or not. And the RNA level or the liver enzymes level does not have much of a prognostic role here. So the option is, which of the following is not associated with the risk of progression of liver disease, or which is HCV infection? The answer will be the RNA level, option B. 9, a patient with chronic diarrhea, fatigue, arthralgia, biopsy showing a PAS positive inclusion in macrophages, which was again typical of Whipple's disease. So I don't, but the exact options for the correct answer will be Whipple's disease. Now, Whipple's disease can present as an asymptomatic carriage in many patients. It can have an acute infection where it can present as acute gastroenteritis, or it can present as a chronic infection, which is called as a classic Whipple's disease, where usually the first symptoms they present as an arthritis. It's an intermittent, symmetrical, occasionally chronic kind of arthritis. Some of these patients can have GIT involvement in the form of malabsorption, and many patients can develop neurological and involvement in the form of cognitive changes, including memory impairment, which may progress to dementia even. And occasionally it can cause a culture negative infective endocarditis as well. So this was again a straightforward question. Next question was regarding a liver abscess, a patient presenting a fever, right upper quadrant pain. And there is a lesion in the liver which has been shown. And the option given was, what is the treatment that will you give to the patient? Option included ciprofloxacin, metronidazole, and azithromycin. Honestly speaking, to differentiate a liver abscess, a pyogenic liver abscess from an amoebic liver abscess is not that easy. But a single lesion is more favoring amoebic, not exactly same, but based upon the question, I feel that that is what the examiner meant. So ciprofloxacin and azithromycin, and nowadays you cannot treat pyogenic liver abscess with these agents also, because many of the organisms are resistant. So suppose the examiner intended to show the option of amoebic liver abscess. In that case, metronidazole will be the correct answer. This is the best way to administer amikacin once daily, continuous 3 times daily, and 4 times daily. Now, this is regarding the PKPD of antibiotics and the best way to administer them. And this we have discussed when we discussed antibiotics, the PKPD parameters. So amikacin is a concentration dependent, and it has a concentration dependent killing. Maximum the concentration, better the killing. And all aminoglycosides are given as a once daily dosing as to have a better PKPD target achievement. And the other thing is that you should understand is that there are some situations where you may give amikacin as a thrice a daily dose, for example, infective endocarditis. where you need a red level which is high due to the persistent bacteremias. But in all of the situations, general situation, amikacin should be given as once daily dosing because it's a concentration dependent kind of killing. So the once daily will be the correct answer over here. There was a question also about an HIV patient. The CD4 count was said to be 43. The patient had seizures, and you had brain enhancing lesions. I was told that it was predominant in the basal ganglia areas. So based upon the CD4, the patients having brain enhancing lesions as well as the involvement of the basal ganglia area predominantly, the options given were toxoplasmosis, TB, cryptococcosis, and PML. The answer will be toxoplasmosis. At this low CD4 count, the most common ring-enhancing lesion that is seen is toxoplasmosis more than tuberculosis. Cryptococcosis can occur, but again, like uncommon and not these kind of large lesions. BML can have lesions, but they are not ring-enhancing. The answer will be toxoplasmosis. 13th question was that patient develops arthritis after diarrhea. Clinical scenario that is suggestive of reactive arthritis was given. And what was the most likely organism was the question. Arthritis can occur after many diseases, especially Salmonella, Shigella, etc. Group Streptococcus is not usually associated. It's usually associated with rheumatic fever. Mycoplasma can cause reactive arthritis, but it's uncommon. Treponema pallidum, not very common. So the answer will be Salmonella over here, reactive arthritis. So reactive arthritis triggers can be enteric infections with certain Shigella, Salmonella, Yersinia, and Campylobacter species, or it can occur after genital infection with Chlamydia trachomatis, other agents as well. In some cases, an esophageal infection with Chlamydia pneumonia or other agents can also cause reactive arthritis. The answer here will be Salmonella. Question number 14 is a patient with nosocomial pneumonia. MRSA is isolated, MIC is 1.5, and the platelet count is 40,000, and drug outflow is. So look at the options. So you have a nosocomial pneumonia and it's MRSA, but the vancomycin MIC is given as 1.5. So whether it is vancomycin susceptible, yeah, by definition, if you have a MIC less than or equal to 2, it is vancomycin susceptible. Can you give vancomycin? The problem here is that when you have 1.5, what is a MIC creep? It's gradually increasing. And there are studies which have shown that if the MIC is more than or equal to 1.5, there is a risk of failure with vancomycin. This phenomenon is called as a MIC creep. That's what I think the examiner would have meant with. And again, why should you add rifampicin? You add rifampicin for prosthetic devices like prosthetic valve infections, prosthetic joint infection, etc. So I don't think rifampicin, vancomycin is the correct answer. Daptomycin, again, the problem is that you don't use daptomycin in pneumonia because many times it is inactivated by the alveolar surfactant. So I don't think that's also the correct answer. Linezolid. Linezolid is approved for the treatment of MRSA pneumonia. The only problem, I think the linezolid will be the platelet count 40,000. Now, I don't think that linezolid absolutely contraindicated when the platelet count is less than 40,000. But what is the examiner thinking? I think because of the low platelet count, I think they would expect to exclude linezolid. There's a little bit of confusion here. So finally, ceftaroline, I think, would be the correct answer. Ceftaroline has been approved for nosocomial pneumonia in some countries, not all countries. So ceftaroline is definitely an option. And I feel that is the option because it does not have that much risk of a thrombocytopenia when you compare it. So considering all these factors and thinking what the examiner will be thinking in his mind, I feel ceftaroline will be the correct answer. So it's a 5th generation cephalosporin with bactericidal activity against MRSA, including strains with reduced susceptibility to vancomycin and daptomycin. And Harrison says that ceftaroline is approved for use in nosocomial pneumonias and SSTIs. And that is the reason by which I think ceftaroline will be the correct answer. Fifth question is HIV patient on stavudine presenting with complaints of appendicular sensory loss and motor weakness, which are also vibration, pinprick sensation loss, and lapse of lactic acidosis, peripheral neuropathy, HIV vacuolar myelopathy, HIV neuropathy, neuromuscular disorder. So the most common peripheral neuropathy that occurs in HIV patient is distal sensory, also called as a painful sensory. As a part of the HIV disease or part of the side effect of deoxynucleosides like stavudine. And it is more common in taller individuals, patients who have a lower CD4 counts, older. Apart from that, stavudine can cause a serious side effect. It's a mitochondrial damage which can lead to hepatic steatosis and as well, along with peripheral neuropathy and pancreatitis. Now, considering all these factors, patient has peripheral neuropathy as well as a patient has hepatomegaly could be indicative of hepatic steatosis and lactic acidosis. I feel that toxic peripheral neuropathy will be the correct answer. And last question is the primary mechanism of there is efflux forms, altered target enzymes, alteration of drug inactivation pathways, or drug modifying enzymes. Now, rifampicin, they target the bacterial RNA polymerase and thereby inhibit the transcription of messenger RNA. So the RNA polymerase. So in the the most common mutation that lead to rifampicin resistance is the mutation in the RNA polymerase. And this lead to rifampicin resistance. So there is a mutation in the RNA polymerase. The structure of the RNA polymerase enzyme is also changed. So there is a change in the target enzyme. So this was a question directly taken from the table on antimicrobial resistance. So rifampicin, the mechanisms inhibited by RNA polymerase and the mechanism of resistance is an altered target enzyme. So the answer will be altered target enzymes, option number B over here. So this, I think, is the last question. Oh, there's one more question regarding a pregnant woman who is having asymptomatic bacteria in the first trimester and identify the correct approach. Whether the screen and management in the current visit itself was screen in the third trimester and treat only positive. Culture now in third trimester and treat only positive. If you have a patient with asymptomatic bacteriuria, only few indications were like you will treat an asymptomatic bacteria in pregnancy is one. In an asymptomatic bacteria, the patient can develop pyelonephritis. Also, it can lead to adverse pregnancy outcomes such as preterm birth and low birth weight. The patient is coming to you, you have to screen and treat for asymptomatic bacteria in the first visit itself. You can wait for the third visit. So the first visit, similar to the first antenatal visit itself, you should screen for asymptomatic bacteria, and if third, you are supposed to treat. Now, there are guidelines which says that you have to have two culture positive, not just based upon one culture, two cultures positive. But that's not like three in the third trimester. In the same trimester, when the patient comes, you take one urine culture is positive, you repeat it, and then treat. So I believe the answer here will be screening and management in the current visit itself, and you don't wait till the third trimester for treatment of asymptomatic bacteria, and that is the option here. So these are like questions, like 16 questions that were from infectious diseases this time, slightly lesser than the last time, but I feel a fair share of ID questions were there. Not very tough regarding the ID point of view. I know that the overall the question had some, like it was considered to be a bit of a tough paper, but the ID I feel has been mostly straightforward questions and easy questions. And I feel that majority of the questions were discussed in the Dr. Tutorial's videos or the discussions that we had in the WhatsApp group. Thank you all. Good day.